This conference will now be recorded.
Okay, AnCan is grateful to our sponsors for making the recordings possible. That includes Bayer, Foundation Medicine, Johnson, Myriad Genetics, Novartis, Telix, Blue Earth Diagnostics, and all of us in the group here who have donated to keep AnCan going. AnCan respectfully notes that it does not accept sponsored promotions, any drugs, protocols, devices that we discuss or recommend in our talks here are based solely on anecdotal peer experience and clinical evidence as we have seen it. Please consult with your own medical provider for personal medical advice, and we encourage you to discuss anything you hear in these sessions with your medical team. So we normally will start with the people who are new in the group. And is it Zolli or Zoli? How do you pronounce that?
Zoli, Longo.
Okay.
It's short for Zoltan. It's good old Hungarian there.
Okay, great. So Zoli sent me some information about his story, and I will share some of that, and then we can ask additional questions. But I think it's pretty clear what he wants to know here. Zoli is 63, lives in Plymouth, Michigan, and first PSA here in October of 2019 was 4. In October of 2023, and at that point, nothing was done after the first one. In October of 2023, it had doubled to 8.4. And a few months later, Dr. Robert Elgin in Michigan did a MRI and had a PIRADS 2 lesion. The MRI showed circumscribed nodules consistent with the BPH, and the other areas appeared free. At that point, he mentioned the size of the prostate was 36, and they said that the PSA density was 0.12, which would suggest a lower risk. The problem was that when that was calculated, the PSA that was used for that calculation was the PSA from 4 years earlier. Looking at the PSA value of 8.4 and the diagnosis and the volume of 36 would give you a PSA density of 0.23, which is on the high side and potentially more concerning. Now you have a bladder stimulator, and because of this, they used a lower field magnet and said there was a lot of artifact and diffuse heterogeneity of the prostate in most of the sequences. So that has been kind of confusing. In March of 24, there was the first biopsy, and 6 out of 12 cores were positive at Gleason 3+3. PSA at that point was 16, and the DRE was normal. The tumor was considered intermediate stage because of the 50% positive cores. A Polaris was done a few months later, and a PSMA PET scan was done in November of 24, and it was asymmetric. There was some differences in the PSMA uptake, but nothing that was convincingly showing evidence of a cancerous lesion. There was significant calcifications in the prostate. At that point, he chose to do a second opinion, and in January of this year, another MRI was done. Again, PIRADS 2 with diffuse signal abnormalities throughout the peripheral zone as well, and the apex, and median lobe was enlarged. No lymph nodes or other issues there, and decided based on this that there are a number of patients who will have invisible prostate cancer, that a biopsy would be done again, and that was done in March of this year. And there was one core with 5% 4, so it was a Gleason 3+4 with 5% 4, and 3 additional cores were 3+3, and they felt this was not consistent with the PSA level that was there. And because of the Gleason 3+3 and the single core with 5% 4, and not explaining the high levels of PSA, surgery was recommended with radical prostatectomy. Did I get you there, Zelly?
You got everything there. Yep.
So what are the questions that you would most like to ask our group?
Well, at this point, we're just in surveillance mode, but I went back to my original urologist, and like the second one at U of M said, oh, let's just take it out. We'll just get rid of it. They recommended the surgery right away, and at this point, I wasn't ready to do that or even commit to it, and so we started addressing inflammation in the prostate, and I was on antibiotics for like 8 weeks. So I'm getting ready to take my next PSA blood test. Anyways, I would think, rather than going directly into surgery, and based on any new testing, that there's got to be other different treatments, and they're miffed at that number, and they're saying anomaly, but you had mentioned something about invisible cancer, so I'm just looking at direction on next steps, I guess.
Well, the two immediate things that I would say, I assume that the biopsies were read locally, and we frequently will advise going ahead and having the slides reviewed by Dr. Jonathan Epstein or Dr. Ming Zhao at Mount Sinai in New York. And what they're finding is 25 to 30% of people will either be upstaged or downstaged, and that would be a good first step. And then the other thing that I mentioned in the email might be to look at things like My Prostate Score 2, the ExoDX or EpiSwitch PSE are all tests that might predict that the disease is more aggressive than not. They are more sensitive than some of the other tests. And I think I would want to know where that is before going ahead. I'm not a big fan. You hang around here a while, you'll see that I'm not a big fan of the surgery because of the high risk of incontinence and erectile dysfunction, which often get better, but often do not. And there are easier things. You mentioned this bladder stimulator. Can you say something about that and why they had to use the low intensity magnet?
I wasn't even aware of that till you just pointed it out. I didn't know there were different densities. I know that I have MRI mode to turn it off. So whether that means...
But it sounds like there's a note in the notes you sent that they said it was a low intensity magnet. Yes. And oftentimes they'll use a 1.5 T magnet as a low intensity magnet versus a 3 T, which is more sensitive and does a better job. So I'm wondering if that might be the situation. Did they discuss that they were doing a scan that might not be as sensitive?
No. like I said, I didn't know there was a difference between, I mean, between 1.5 and 3, but they did not mention that they did it at a lower density and it could have missed something.
Yeah, I mean, that's a possibility too. Stuart,
Were both MRIs the lower level?
Yes.
Okay. Uh, the one thought that comes to mind is the micro ultrasound. Because it's supposedly sensitive, and given the fact if the MRI they can't use the full power because of this, that might be something worth exploring if you can
Okay.
find a doctor either at the U of M or someone that has access and is knowledgeable on using it. That might help, because it's sort of weird. All of the evidence that they're giving you, suggests there's not much there other than the PSA score. And so
Exactly.
my totally non-medical opinion is, unless there's a really good reason, I wouldn't be considering surgery. But I would look for other, the the micro ultrasound or these other blood or urine tests might really help in this case, because MRI you would normally trust a lot on, and PIRADS 2 normally wouldn't even get followed up. Why did they do the PSMA scan?
The PET scan.
Yeah.
I don't, because they were, like I said, they were miffed, and then there wasn't one sure going on. They didn't want to know if they missed it or if there was something there that it wasn't metastasizing.
so I'm Stuart. I'd be concerned that if they were seeing calcifications in there, I know that you can't do HIFU or TULSA with calcifications, and that's ultrasound, and I'm wondering if that would deflect it, and you would just see a snow field and not be able to make something out if there's truly a lot of calcium in the prostate already.
True.
But it'd be worth trying.
It'd be worth exploring, just because if the MRI you're limited, it supposedly can be as good as an MRI, so it's just another option.
Anybody else have comments here or questions? I don't know if you have, and I need to have this handy each time. Stuart, you've been posting, I know, in the past with Ming Zhao's and Dr. Epstein's contact information. If you have that handy, that would be great to make available. It would be nice, maybe Rick, if you know if that's something we can pin to the thing here to keep track.
Well, we have to put it in each time before we can pin
Okay.
it. We can't. The
You can't have
room
it
won't
today.
open with that information in it,
Okay.
because it doesn't know who's coming into the room.
Okay. So again, I think
Now
the
here's the man who has it at his fingertips and will post it in a heartbeat. He just joined.
Eric, did you hear that? We're suggesting that perhaps you would have information on Dr. Ming Zhao and Dr. Epstein's contact so that
Sure.
we can get that back up there.
No problem.
You missed on Zoli. He has a high PSA, pretty normal sized prostate with calcifications and diffuse issues with it. But one biopsy was 50% Gleason grade 2, And then he had another biopsy. That one was a transperineal biopsy, and it had one core with 5% 4 in it. So there's nothing that is evidence of significant risk other than the PSA, which is high. And then he's been advised to consider radical prostatectomy. And I advised that the first step would be to get another opinion on the pathology,
Yeah.
and then look at something like My Prostate Score 2 or EpiSwitch PSA. Even Artera AI might be a helpful tool. It may say, well, I don't know what to do in this situation like your docs, but it might also say that you have a really good chance, despite the unknown, of just staying on active surveillance and monitoring.
So, I'd say a couple of things on this, if I may, Zali. First of all, the doctor who gave you a report that had a Gleason grade 2, is that the same doctor that wants to do the surgery?
Well, they both want to do the surgery.
Okay, well, let's just start with the one who gave you the Gleason grade 2.
That is the new doctor, Dr. Wood,
Okay, and where does he practice?
U of M.
U of M?
Yes, Michigan Medicine.
Wow, that really took me back. Is he part of the music consortium?
I don't know. He came in shaking his head and he was befuddled. And I'm like, well, what'd you go to med school that whole time for? And
I mean,
yeah, I had zero confidence in him.
well, first of all, the music consortium, which is run by U of M out of Ann Arbor,
Okay.
and has a number of people in it throughout the country, throughout the state, is very, very pro active surveillance.
Okay.
And my
Okay.
suggestion would be that you get another opinion from one of the docs that we know. I would send you in a heartbeat to Todd Morgan. Now he may be in Ann Arbor, and that may be a bit of a schlep for you.
Oh, that's close.
Okay, well, I would say you need a second opinion from Todd Morgan. Tell him you came from AnCan. Tell him what's going on, and that's who that's the first stop. The second stop is, I don't know who's giving you a Gleason grade 2. This is probably the first Gleason grade 2 I've heard of in 15 years. We don't use that any longer. Anything that is considered to be a Gleason grade 2 is graded as a 3. We don't use Gleason grade 1s and now if it was a grade group 2, that's different. If it was a Gleason 2, I don't know what they're talking about.
I'm sorry, I misspoke on that. It's a Gleason 3+3, grade group
Okay,
2.
it's a Gleason.
Grade group.
Well, that's grade group 1. Grade group 2 is 3+4.
Okay, yes, it's 3+4 in the one core with 5%, and it's Gleason 1 with the others at 3+3.
Okay, so what we're looking at here is a very small amount of 3+4. However much 3+3 you have, you shouldn't be worried. And momentarily, we'll call on Eric, and he'll tell you how much 3+3 he has. You should not be worried about your 3+3. You should be concerned about your 3+4, but you have very, very little. And it sounds to me, from what you're saying, I'm not giving you medical advice, but if I had your numbers, I would be looking at active surveillance. I'd be joining the group on Wednesday night. Eric is one of the moderators in that group, and I'd be talking to them. And I would be going to, and especially since you have other issues, you have other urinary issues, why aggravate them?
Okay.
And I would also be going to one of the really good docs. Todd Morgan is one. If you can't get an appointment with him, Arvin George is another one. Arvin George, George. I'd be going to see one of them and saying what's going on, because the likelihood with both of them is they're going to say, yeah, you're a good candidate to watch your 3+4. That's
Okay.
my 2 cents.
Yeah, thanks. And sorry earlier, I thought you were making a joke earlier, and I didn't know the music thing was a thing. But yeah, I understand it now. Thank you.
The music is a really, really, I think it stands for Michigan Urology. I don't know what the SIC is, but they have done some terrific work on promoting active surveillance, and they have probably the highest participation compliance with active surveillance in the United States.
That's awesome. That's good to know. That's 20 minutes away.
So, if you're at a University of Michigan satellite clinic, get out of there. And now sometimes there can be problems getting in there. If you have any grief, let us know. You can let Dr. Mark know, or Eric, and we can use our own. We have a little bit of clout there through the doctors we know and through Howard Walensky.
Okay, great. Thank you so much. That's awesome. Thank
Eric,
you.
were you going to comment too, as well?
I'm just coming in at the end, so
Okay.
I don't know what I'm
A
commenting on.
situation with creeping up PSAs from 4, and a couple of years later now it's 22.8, and PSA density is slightly high, and the MRI was a 1.5T magnet and not a great scan, and it only reveals PIREDS 2. First biopsy was 6 out of 12, Gleason 3+3, and the second biopsy had one core that was 5% 3+4. So the 2 docs that he had seen earlier were recommending radical prostatectomy because they didn't know why the PSA would be so high with the negative MRI and a biopsy that wasn't impressive.
Okay. Well, if he had high PSAs, was that because of any exercise or anything before the blood draw? That's always a possibility.
He's been treated with antibiotics and getting a follow-up PSA coming up soon. I don't think that exercise would bring the PSA up to 20s. I'm not sure, but
either that or inflammation of some sort in his prostate that could trigger something like that. But if was it a big jump, like from 4 to 22 in one test, or
over 5 years, 6 years.
6-year trend?
Yeah.
Okay. How are you having any urination issues?
No, just sometimes, frequency.
At night and sleeping, or?
One time during the night, and probably throughout the day.
Okay, it could be
Hour and a
BPA.
half, and you had mentioned the inflammation. That's why they're doing the antibiotics for 2 months and try to get rid of the inflammation. Then I'm within a week or so, I'm getting another blood draw.
Okay. Just make sure before the blood draw, you don't do any bike rides, have sex or ejaculation or strenuous lifting or have a cold or the flu or anything like that, because
Okay.
that'll skew the results.
Yeah, and some of that, is it 48 hours or longer?
Yeah, 48 hours is probably the minimum, 36 to be safe.
Okay.
Just be a lazy bum.
Gotcha.
The information on Dr. Ming Zhao and Dr. Jonathan Epstein are posted in the chat window. Do you know how to find the chat window in this?
Um,
There's a little body up near the top that has a 15, and just to the right of that, you'll see some white
yeah,
squares, two on
got it.
top of each other. Okay, and it's in there. And I think
Okay.
that's a very important step in this process, again, because they've seen 25 to 30% errors. These guys are just looking at prostates all day long, as opposed to someone in a local facility where they may be doing a little bit of everything under the sun when it comes time to pathology.
Sure, sure. That's awesome. I see it. I got it. So
Okay,
thank you.
great. Any other questions for the group? Stuart, you've got your hand up.
Yeah, it just occurred to me now, since you went to, did U of M do one of the uh, MRIs?
Yes, sir.
Okay. It just occurs to me because I've heard the head of radiology do in New York do some uh, presentations, and they're again grasping at straws here, but it might be that if you find a really, really good MRI radiologist, that they may have a better solution for you that might get you a stronger MRI. I know this guy was talking about what they do with people with pacemakers and how they deal with it. And the really good practitioners have some really aggressive ways of trying to deal with that, which might also just be a help for you because anything that could just get you a better read would help make you comfortable that you don't have anything really concerning to worry about, even though you've got a high PSA.
Yes. Well, yeah, yeah. Thank you. I'll look into that. I'm not adverse to having it removed either. The stem unit. The
You
bang for the
should
buck.
be. You should be,
Yeah.
particularly if it's not warranted. I mean,
Okay.
going into the operating room at our age is not the same as being in your 20s and getting your appendix out.
Gotcha.
People can have serious life-threatening complications from surgery. So if that's the best thing for you, then go ahead. But as I mentioned in the email before, for most people, the benefit comes if they're self-cathing and if they have to catheterize themselves, then they'll have relief. Some bladder problems may warrant that going that way. But otherwise, there really isn't any benefit when it comes to looking at the risks and the side effects of surgery compared to modern, good quality radiation. Again, if it's not done by great machines with a good team of people managing it, you can run into problems with that too. Eric.
Yes, forgive me again. Was there an issue with the MRI because of a pacemaker? Did I
It's
hear
an inner stem for the bladder. It's in my backside.
Sorry, say the first part again.
Inner stem, a stem unit for the bladder, nerve
Okay.
block, basically.
Okay. Have you looked at, or has anybody mentioned the micro ultrasound as an alternative?
Yeah, Stuart mentioned that. One concern is that they did find a lot of calcium in the prostate, and that may make it real hard to read.
Gotcha.
And the calcium can screw up things like HIFU and TULSA-PRO.
Got it. Okay. Thank you.
Okay, then we'll move on here. I wanted to check again with a few people who signed in late Mike, are you going to need some time today? And have you been here before? And if not, then we'll check in. Jill B., are you going to want some time this evening? Have you been here to this session before? You are muted if you want to unmute yourself. Eric, are you going to want some time?
No, I'm good. Thank you.
Okay, great.
Jill B is replying in the chat window.
Yeah.
And also indicates they would prefer not to speak. That said, they've posted a question that requires some time, so maybe you can moderate that question in the chat window.
Yeah, I shot a brief answer back to Jill earlier.
Okay.
So, okay, David, you're up. Unmute. You're muted.
Lots happened since I was last here a couple months ago. I started orgovyx on March 22nd. Today is day 67. I'm actually pleasantly surprised. I've really had no side effects from it at all. I started worrying it wasn't even working, but I got my first blood test after 30 days and it is working. And the question I've got has to do with orgovyx, but before I ask the question, I'll just tell you what else has been happening. I had a bone density scan and it showed normal femur, normal hip, but slightly osteopenia in the lumbar spine. Just one point below normal on that. Just had a colonoscopy, and I've lined up treatment for July, which will be IMRT to the prostate and lymph nodes, plus a HDR brachy boost. And I'm waiting intentionally for 3 months to go by that I've been on orgovyx before that happens. Everybody says that's what I'm supposed to do, so that's what I'm going to do. And so my question has to do with orgovyx. I had my first blood draw with orgovyx about not quite 30 days into orgovyx. Before orgovyx, my most recent PSA, which was in February, was 6.1. And so on day roughly 28 of orgovyx, it was down to 1.2. And tomorrow I have my next blood draw. Now I was just today pondering, gee, I wonder what should be the target for that? Like what's good and what's bad on day 67? So I saw some orgovyx literature on the web that said by this point my PSA should have dropped by about 86%. If that's the case, then it should be somewhere around 0.85 or thereabouts. And I also saw a study published last year by lead author Martin T. King in the journal Cancer, and in it he had tracked 350 guys for 10 years and concluded that the PSA that they had after 10 weeks of ADT prior to radiation mattered in terms of their all-cause mortality. Now, I don't know why they went with all-cause mortality instead of prostate-specific mortality, but they did. Anyway, he concluded that if the PSA is above 0.5 after around 10 weeks on ADT, then you're going to have a higher risk of all-cause mortality
Right.
than if it's below that. But according to the orgovyx literature, my PSA is only, if on average, going to be dropping about 86%.
Let me stop you because we don't spend a lot of time talking about orgovyx in here because most of the people that are using it are doing it like you for a very short period of time.
Okay.
by and large, I think I might be familiar. There's a study I just highlighted this week in the advanced group, and I think Mark read it, which has to do with what your PSA was prior to surgery.
Okay.
And this is sort of the same thing,
Yeah. But with radiation.
but with radiation, the reasoning is the same.
Yeah.
What they're saying, I think what they're saying is that, well, there's a couple of things. First of all, it's not pertinent to you because these studies are done with men who are usually going to be on long-term hormone therapy,
Okay.
meaning
All
at
right.
least 9 to 12 months.
Okay.
So all of the all-cause mortality stuff has to do with the metabolic syndrome that arises from long-term use of hormone therapy.
Okay. Got it.
Okay, and we know that long-term use of hormone therapy can cause many issues, including many heart issues.
Yeah.
And so and increases in cholesterol and fat around your waist, which is highly correlated with all-cause mortality. So what they're looking at is something a little bit different to what you're interpreting, and this is one of the problems when if you don't have enough education and you dive into Dr. Google, you come up with stuff that it can really concern you, and it really isn't related to you. I think
Okay.
first, where should you be after 67 days? Well, if you were on a agonist, I would say probably your PSAs come down about 2/3 of the way. If you're going to respond, and in another month you'd be down all the way.
Okay.
If you're on an antagonist like orgovyx, I don't have as much experience because it's a lot more recent. I'm not sure what Sumitovant says, but my guess is that you'd be pretty close to around your nadir at that point in time. Maybe within 10% of your nadir. Nadir is the lowest point.
Right. Right. And are you saying then in my case, since I'm using it short term, what my nadir is doesn't really matter?
No, because all they're doing it for is to bring your testosterone down, to shrink the size of your prostate, to make it easier to radiate.
Right.
Now, if you went back on, yes, we would be concerned. And when we see guys who are on longer term hormone therapy, and after 3 months they're not really at a low point, it can give us, it's a red flag, it's an amber flag, because some guys do take longer. But certainly by 4 months out, if you've got issues and you've got more aggressive prostate cancer and you haven't come down all the way, then the lights are flashing a little bit.
And in terms of duration, short-term duration, different doctors have told me different things. Stay on it for 4 months, stay on it for 6 months, stay on it for 9 months. Is there a ideal
What's your were you a 4+3?
Yeah.
I would say 6 to 8. I mean, if it were me, I would say 6 to 8 months.
Okay.
I wouldn't drop it after 4 months.
Okay.
Okay. I would say 6 to 8, 6 to 9. And then, higher, if you're 4+4 or higher, that's another discussion. But I think that 6 to 8 is a reasonable and appropriate period of time, and it should come back pretty quickly Since you're on orgovyx, it's going to come back a heck of a lot quicker when you
Mm-hmm.
come off of it.
Mm-hmm.
Rick, when you're talking about that duration, is that including both before and after, or
Yes,
the duration at just after? Because
before and after. For
I
the total
mean,
period of time from
I've
when you
seen,
start to when you finish.
okay,
What
I've
do you
seen things.
What do you mean before and after? I mean, when I start and when I finish taking the pills, right? Or is there some
Yes.
other? Okay.
Mark's asking whether that should be 6 to 8 months after the conclusion of your radiation therapy.
Oh, I see.
And I'm saying no, it's the whole period that
Oh, I
you're
see.
on.
I see. Okay, got it. Okay.
I've
Okay.
also seen conflicting evidence about using the drugs beforehand. I think now more is leaning towards at least 1 month before, and it's more about getting the testosterone down than actually causing a benefit. Um, but in your situation, if they're doing HDR, it may very well be that the prostate is somewhat enlarged, and the
Yes.
shrinkage is to facilitate doing the HDR.
Mm-hmm. Mm-hmm.
And as Rick said, I think it's important to see that they did all cause mortality, which is not saying that what you're doing when you start and what you see here is going to affect the ability of the radiation to treat your cancer. That should be there. It's really a factor that if you take the stuff for too long, you can start having other problems. And, as we note in prostate cancer, more people are going to die from heart disease, stroke, than
Right.
they are from the cancer.
Okay. So that's
Particularly,
why.
that would be a situation that someone with a 4+3 like this would experience.
Okay.
So it's so hard to control all the variables. Look at a study and say, that's exactly who I am. So now I know what my prognosis is going to be and how I will respond. It's
Mm-hmm.
very hard to do that.
Okay. Okay. Great. Thank you. Thanks for the info.
Stuart, you needed some time.
Yeah, this Wednesday is I have my 6 month follow up my doc after post treatment, and I'm just trying to organize and plan myself in terms of what to expect and what possibly to look for, or what to try and get information from the doctor. And part of what makes this a little bit unusual is that since I'm in a clinical trial, there are, most of the standard benchmarks don't necessarily make sense.
Yeah, I mean, I would ask those questions exactly. It'll be interesting to see. The Retire study used IRE or nano knife to the main lesion, and then treats the rest of the prostate, the entire prostate, but at a lower dose. And the goal with that is to try and reduce um, recurrence, but also side effects. So it will be interesting to see where that comes. And I'd ask whether they've decided to treat anybody outside of the protocol and to continue to offer that combination. If they have the stuff for IRE, they're probably doing IRE. So are they doing a cleanup radiation in anybody else now that mimics what was done in the study?
The other question that I have is just, have they, anybody in the study, do they have any suspicion of recurrence? Or is everybody still clean?
Yeah, I mean, also if there's been any PSA rises, um, and where they are with bladder, is there a tendency to believe that this is going to reduce bladder and bowel side effects. So that'll be interesting. And it was done with MRI machines. I would be interested in knowing whether that same kind of approach with the IRE combined with the lower dose radiation might be done with different than other than MRI LINAC. I posted an article, I think it was on one of the Facebook groups, about the difference between a VMAT IMRT and the MRI LINAC. And certainly they chose to go with a more precise system in doing that study.
That's probably a Dr. Nagar question.
Mhm.
This appointment is with Dr. McClure. So, but the one thing is that my 6-month PSA crept up slightly. It was 0.59 at 3 months, and it's up to 0.72, which I'm going to guess he's going to say that's nothing and no concern, even though it is 20%.
So, I mean, that's an interesting thing there is that, the findings supposedly with the prostate intact or there would be a rise of 2 above the nadir. Is the criteria for diagnosing biochemical recurrence going to be the same with this study when you've not totally irradiated or fried the prostate with radiation? So, how would they measure and define trending upwards from biochemical recurrence? Rick, did you have a comment?
No. The only thing I did want to say was to Zoli and to anybody else, if we do not have your email, please put it in the chat window. If you're not receiving our reminders and you'd like to receive our reminders, and we'll make sure that you get in. If you don't want to put it in publicly, if you put it in publicly, then it won't get reproduced anywhere, but other people in the group might want to reach out to you. If you do put it, if you don't want to put it in publicly, send it to me or to Mark by clicking the little arrow in the very bottom right-hand corner and selecting, or you can select organizers. It'll go to both of us. But if you do that, then we will. And if you do that, Zoli, you'll get the reminder, the active surveillance reminder, which I think is probably going to go out tomorrow morning.
Okay, great. I'll do that now.
Okay, I wanted to thank Colonel Boykin for coming here and let everybody know that we are recording this. So if you missed something, want to review it, or you want to refer a friend, you can go to the AnCan website and find these documented. And that's thanks to Boykin Jordan for doing that. So thank you so much. And then David, will you want some time in later on?
Thank you for asking. No, I'm good. I just wanted to check in with you, man.
Okay, we'll come back around. Let's go through our list.
And I have something else. I have another big thank you to Colonel Boykin. So all of you, if you're on the AnCan mailing list, received the Memorial Day post this morning, which was beautifully written by Colonel Boykin, and we're very grateful to him. It was very, very appropriate, and we thank him for those words.
Thank you. Michael, you're up.
Mark, appreciate. Congratulations for published book for your grandchildren. I guess my wife also does that. She made a kind of published book for her grandchildren. Anyway, I got a question. I have my 4th biopsy in late March, a transparent biopsy at University of Denver. Essentially 16 sample, and 2 of them is 3+4, and pattern 4 is 20%. I sent out to Dr. Johnson Epstein, and he looked at that and he said that, well, there is some large cribriform in one of the sample. So, but my wife and I have discussion with him twice. The final discussion with him, he said that, well, essentially, based upon the data that you provide to me, metastasis would take years. So my data is essentially my decipher score is 0.19. My PSMA PET scan showing that essentially all inclusive inside the prostate itself. 3 consecutive MRI for the last 4 years have been stable. There's no change on that. And my PSA density about 0.156. So recently, I also have consulted with Dr. Mark Scholl, and he gave me 2 choices. One of them would be potentially focal treatment. The urologist in Denver also say that he can do focal treatment for RE. But then after I provide all the data to Dr. Scholl, he seemed to kind of say that for the last 4 years, a lot of urologists been looking for the so-called the Goldilocks, the definitive answer for what makes cancer, prostate cancer metastasize. Nobody has found that. So he said to me that probably you still can continue active surveillance. Have another MRI toward the end of this year and continue every 6 months take PSA. So I'm just curious whether the panel and Mark and Rick comment about cribriform and where they stand in the so-called hierarchy of aggressiveness and of the disease.
So you're asking us, in my opinion, a somewhat impossible question, because if we were blindfolded and the only thing we could see is a pathology report that said cribriform pattern and large cribriform pattern, we would be concerned. Now, what that doesn't tell us is how many cores were involved, what part of the area was involved, what did the decipher score show?
0.19.
All the other factors that might go in. That study wasn't done. I can't tell you large cribriform pattern with decipher of 0.19. How much do you weigh each of those findings to come up with a meaningful answer? If the only thing you know is large cribriform, I would say, that can be concerning. The other side of that is, let's say we know that no matter what all those other things come back at, that cribriform pattern is a bad bugger that at some point is going to act bad. So the next thing you want to know, is that going to change if you treat it? And that study hasn't been done. I can't sit down and tell someone that, yes, you have cribriform pattern, and it might mean that your disease could be more aggressive. It doesn't tell me that being more aggressive in treatment is going to give you a better outcome. So I don't know that we have the answer. And I don't know. Rick, do you have thoughts on that? You need to unmute.
To me, if Epstein is telling you you don't need to worry, I don't think you need to be asking us. That's the first thing. The second thing is, have you listened to that video, that 30-minute video from Euro Today and others? That it was actually from the UCSF. What do they call it? Review session. I forget what they call it. But have you listened to that, Michael?
Yeah, I did. Is that with the Dr. Matt Cooperberg and with the
right? But it was the fellow. What was it? Jay.
Yeah, right. I did. Yeah.
So you know as much as we do, man. First of all, as you know, since you listened to it, was different types of cribriform. I mean, what did he have? 20, 30 different types of cribriform on that chart?
Right, right.
So the first question is, well, which sort of cribriform do I have? Because we can't say to you, well, you know, if I've got cribriform, what does that mean? Because we're now learning that cribriform, which is really something that Epstein was the first person to point out 10 years ago or more. Can't remember. I think I've got his article somewhere. But he was the first person to point it out. Now we know that there's a lot of different types of cribriform. And so if you're showing it to Epstein and Epstein's saying, don't worry, I don't know how much more information you're going to get out of a peer-led group like us. With great respect to our medical leader here, I think he might probably even agree with me.
Absolutely.
Yeah, that's interesting because in fact I did ask Dr. Epstein the following question. I said to him that if cribriform that important, how come medical school and other urologists have not been provide that information in the biopsy? You know, many people I know receive biopsy, our pathologist report never mention about cribriform. Kind of interesting.
And why are people, Michael, and why are people doing biopsies without an MRI?
Oh yeah, well,
I mean,
really,
medical care in this country is not dictated by what makes the most sense. I don't know what causes people, a significant number of people still to do biopsies without an MRI. One of the people who recently published, and I don't know if this is who you were referring to, was Dr. Jesse McKinney. And
that's the man, yeah.
Cleveland Clinic or
Yeah, that's
Case
the guy.
Western.
That's who I was referring to.
Yeah. So, I mean, you could send stuff off there, but I don't know if it's going to get you to a point that it can inform you what to do.
Thank you.
Okay. Let's see. We've got some hands up, and I guess it was Stuart first, and then Eric. If not, hang around. We'll get to everybody. Stuart.
Michael, you've got, again, it sounds like you've got some conflicting information, but I think ultimately in your case, it's less about necessarily the cribriform or whatever. I think it really comes down to what makes you feel more comfortable. If you're comfortable not treating, but being actively being very active with your surveillance, I would look to get a doctor that supports an aggressive active surveillance program. And if you're comfortable and can go to sleep at night and not worry about that, that would basically remove the need to treat. And by the other token, if you're really uncomfortable by the stuff that you're seeing, well, that's really, I think, going to be the ultimate decision that you're going to want to make is the one that is going to make you the most content in terms of thinking about your prospects going forward.
Yeah, thanks, Stuart. I mean, I'm probably, because of my background academic, I agree with Mark. It's pretty much that's why is something not being done. That's why a lot of people say medical science is still an art, it's not the science.
Look, we're not here to solve the medical crisis in this country and why urology treatment is as bad as it is. We know it. And I don't think that's a good use of this forum. I think what is a good use of this forum is for us to point it out to people who don't have the knowledge and make sure they get the knowledge. I think that's where we serve our purpose. I've been working back and forth with a guy in the active surveillance group, which I rarely do, but it happened to be around the early diagnosis guidelines for prostate cancer. And This was the gent who was biopsied on a blind biopsy. And when we heard, we said, that's ridiculous and it shouldn't be blind. So we went back to his doc and he said to the doc, well, let's get let's get a biopsy with an MRI. And the doc said, what do you need an MRI for? You don't, we know you have the cancer. I'll just go in and biopsy you again and go into 12 different spots. And we said, oh my God, I mean, this is like from the dark ages. And I said, this guy needs reporting. Then I looked and he found the guidelines and he sent them to me and he says, well, the guidelines say you may need. And he was 100% right. And I looked, and when we reviewed those guidelines in 2023, and we all reviewed them, Mark and I can't remember who else, the guideline said may, and we put in our comments, it shouldn't say may, it should say should. And we put that in the comments. But the AUA didn't pick it up. Why? Because they need the weasel language. Because if there's a doctor who doesn't do it, then, we complain, they're going to say, well, it doesn't say you have to do it. Yeah, but all the bloody studies say you have to do it. And that's why we've got a problem. So organizations like ourselves are working as hard as we can to keep these doctors tracking, but we're not getting there. And so the best we can say to you is, if a doctor doesn't follow the best practices, you have to find another doctor. Then you get into the issues of second opinions, and some people are very uncomfortable getting second opinions, and some doctors are uncomfortable with patients who get second opinions. I've actually been thinking in the last 2 or 3 days that we probably need to do a study around that, second opinions. I think it would be very interesting. I think we may find an academic partner who would do it with us, and then we could at the same time survey the doctors and the patients and see where the difference is. But that's for future. Sorry, I was verbose.
That's why I and many people really appreciate you, Rick, and I Mark, the leadership for AnCan. I want to let you know that I really appreciate you're learning a lot from you guys. So thank you.
I wanted to also mention that I think, and this is something that I saw in my practice, there comes a point when the indecision or the inability to find someone you can trust can be as bad as the whole process. So I think one of the important things in here in the group is to help you understand, are you getting information from someone you can trust, or is it time to go elsewhere? Once you find someone who you can trust, you've got to understand that there may be a lot of people who are very competent physicians who are going to have different opinions, and failing to make a decision of who you can go to and who you can let drive the ship can be an obstacle along the way that I think needs to be addressed. And let's see, Eric, you've got your hand up.
Hey, thank you, Michael. Good to see you again. I don't know if you mentioned it, and I don't know if it has any weight, but did you have any urine tests for aggressive cancer that might help you?
Are you talking to me? I mean, essentially, I did not, but essentially, I have prolaric and 2, what do you call it, decipher, and essentially, that's what I had.
Okay.
Thank
I
you.
mean, you could go to another test if you feel like you need more data, but that's up to you in the end of the day. So I think it's ExoDX or one of those. I could be wrong. Somebody help me, but they detect aggressive cancer cells through urine. So if you want some other guidance in terms of data, that could be an avenue to consider.
Thank you.
Okay. If that covers it, let's move on to Jeff W.
Hi, everybody. Yeah, my issue of the moment. Last week, I saw my urologist, and the topic that's come to the top of the list now is BPH. I have mild BPH, and by mild I mean my only symptom is weak stream, but I've done a couple measurements myself, and peeing at a rate of 10 milliliters per second, which Google tells me is the low end of normal.
So, Jeff, can I just take a time out? This is not the best group for BPH. The BPH knowledge of AnCan is really in the active surveillance group. So yes, you can bring it up, but the BPH is not usually something that we discuss in this group.
But what's your cancer? Let's hear the other side of the question. What's the situation with the cancer as well, and how does that interact with deciding on treating the cancer?
The big question is, do I need to get the BPH treated prior to the cancer treatment, which at this point looks like it's going to be radiation? Does it have to be before radiation, or can it be after?
That's tricky.
Yeah.
Can you fill us in on what, how many times a night are you getting up, and what kind of cancer are they treating with radiation, and what kind of radiation?
I don't know yet. I'll see I've seen one radiation oncologist here in Austin. They've given me their take on things. I'll see another radiation oncologist on June 9th, Henry Moak, M-O-K, at MD Anderson. Basically, that'll be my second opinion. Let's see. So I had biopsy in August of last year, August of 2024. One lesion, Gleason 3+4, 10% pattern 4. What else can I tell you? My PSA on March 25th of this year was 8.5, so I'm feeling some urgency at this point. I did find, I thought, the urologist of last week told me a month ago that I was a great candidate for focal, but then he looked at my MRI images and he said, well, you're not a great candidate for focal because you have some cancer. Your first MRI back in 2021, when I was first diagnosed, I had Gleason 3+3. So I was on active surveillance for up until, well, I still am on active surveillance. But the biopsy of August of 2024 showed that the main lesion in index number 1 had gone from Gleason 3+3 to 3+4 with 10% pattern 4. So that was the trigger that I figured out, okay, I'm going to end up having to get this treated.
Okay.
But,
so let me try and divide this up, and then we'll go on further. I think looking at each of those factors individually, the cancer itself, it's fine to look at active surveillance. A 10% 4 in one core doesn't push you to need radiation treatment. There is some chance that the radiation could cause swelling, and that could be problematic. Choosing to go the surgery route would end up having you use a catheter, which in the worst case scenario would be temporary with radiation until things shrunk down. I think it's important the type of radiation. You'd want to look at, there are a lot of different machines, but VMAT is one of the technologies that rotates the beam. And then there's also at, I think Dr. Mocha is a person at MD Anderson who's experienced with Electa Unity. system, which is an MRI LINAC. That's the most precise. It has daily adaptive planning. So if the prostate grows or shrinks, it's going to adjust the treatment to compensate for that. And if there's any movement in your prostate that would get to the bladder, it's going to shut the machine off or make an adjustment live. So I think the type of radiation matters on it, but you're at a point where if you're not getting up 3 or 4 times a night, a little weak stream, that happens to a lot of guys. The cancer itself isn't something to do. Now, there's one other thing that I'd ask about, and that I'd ask about whether with BPH, one of the things they'll do is try to shrink the prostate with finasteride, and that might help to a point where you've improved the urinary symptoms and then decide what you want. I'm not convinced that focal is the way to go to treat cancer. Incidentally, it may delay cancer getting worse, but if you have a cancer that is going to need treatment, it'll probably need it at some point. So if I was looking at focal, something like TULSA, the option would be, I know it's not going to be approaching a cure of the cancer, but it may improve the urinary symptoms such that later on I can do radiation and not have to worry about it. If you do radiation, they could prepare you to do self-cath if you needed it, and it probably would not be that likely. But I can't say. Do you know how big your prostate is?
57 cc. So the urologist said last week, well, it's plump. I asked him, do you think I really need to get BPH treatment? And he hedged a little bit and is leaning towards, well, yes, However, the only real the main symptom that I have is weak stream, but again, it's not that weak. I get up once a night. Some days I have to pee frequently, but not every day.
Yeah.
So that's a tough one.
Stuart, he needs to go to New York, and they need to open up the retire study again, because that would be the perfect situation for something like this, where at least you're dealing with the lesions and maybe some of the BPH symptoms. But it sounds like Rick was right from the beginning that active surveillance may be the way to go, and managing any symptoms while you're on active surveillance probably would save you a lot of grief.
Yeah. I'd say a couple of things, Jeff. I'd say, first of all, 60 is not that large. It's on the larger side because the average size is 40. It's a little bit large, but there's a lot of guys, especially older guys, with 60 cc prostates. When you hear of guys that have prostates of 150 and 200 and 300, that's large. So I would say the other thing is that, yes, that group does know a little bit more about the alternative treatments and they can talk about it. I did want to ask if anybody in this group has any experience with BPH and has anything they'd like to say to Jeff about BPH. Eric.
Yeah, my stream has gotten slower over time, and luckily I still sleep through the night. But I do try to reduce inflammation in general just by good nutrition choices.
Yeah, I've done the same.
Blueberries and all that kind of stuff. And there's studies even on cranberry powder, which I sent to you as well. So who knows if that could help. But hey, it's free, it's cheap versus actual treatment options.
Yeah, my larger picture right now is that I've made a lot of big dietary changes. Well, I always ate pretty well, but I've really, dialed it in these past 3 or 4 months. And I'm wondering, what effect might that be having? Well,
I'll get a PSA test. I get a blood test for my annual wellness exam on June 18th. So I'll have a PSA test here, in the next couple of weeks. On top of that, my last MRI was July of last year, biopsy of August of last year. So it's like, oh, so, it would be time typically to get another MRI. And I'm really curious to know, where things are at this point now. So I throw that out there. But the urologist of last week, he said, well, that when you get the BPH treated, he was recommending aquablation. When you get the BPH treated, you get a biopsy at the same time. And my mind was teeming with questions, and the session, the meeting, the appointment ended without my asking him, wait a minute, biopsy without MRI? So I got a hold of his office, sent the question off, have not gotten a response yet. My last MRI was July of last year, but
Jeff, you have to understand something, that these bloody urologists are like used car salesmen. And if whatever they can add on, we can add on a BPH treatment. Oh, we can add on another biopsy. This is how they are, and especially in Austin, we've seen it. This is why we're saying to you, get rid of this dickhead in Austin. When you go see Dr. Moak, ask him about the BPH. He's going to be the best person. David Keller, what have you got to say?
Well, only what a lot of you already know about. I didn't hear him talk about his prostate density index. And that would be important for you, Jeff. If I understood you right, your PSA was 8.5 and your prostate was 60, and the prostate density index is the PSA divided by the size of your prostate. So in your case, it's 0.19. And the research shows anything under 0.15 is considered okay. Obviously, it's one metric of many, but it makes sense to have a correlation between the size of the prostate and the PSA, because the larger the prostate, the more PSA it puts out. So I just wanted to throw in the prostate density index into your mix so you could have it in your notes. Thank you, Rick.
Yeah, I know that data point, and that leads me to wonder whether the PSA reading of 8.5 might have been, just like A. So it puts a lot more weight on my curiosity of what it's going to be, here in the next week or so.
Yeah, it's the PSA is always that day because that's when they do the blood draw.
Yeah.
So it's all about the trend. It's trending. What's the trend doing?
Yeah. So
Jeff, I was thinking that when he talked about doing the biopsy with the dealing with the BPH, my suspicion was he was planning on doing a TERP where they go in. No? How's he going to do with BPH?
He was recommending aquablation. So I spent a couple of days I've spent enough time now weighing BPH options it came down to, it was looking like HoLEP versus aquablation, and they're so close. The big difference there is that HoLEP, seeing that they say 70 to 80% of people experience permanent retrograde ejaculation, whereas aquablation, that's not the case. I read that Medicare does not pay for aquablation. The urologist says it does. HoLEP, Medicare does. So HoLEP is more.
Again, I'm wondering also about the pathology on that, as to how, if you get a bunch of disrupted cells, how valuable that is. Even with regular biopsies, we assume that they get tissue and it's going to be reliable tissue. The quality of most biopsies that are being done for this is really pretty awful. The tissue is ripped apart. You have gaps in it. it may be folded over, which makes it hard to read in the containers. And there are some people who are developing newer systems for doing the biopsy that really gets you a better quality biopsy that you can see. I'm sure aquablation, if it gets you a biopsy, it's more likely to be compromised and not,
Yeah,
big enough pieces of tissue to be making decisions on. But it doesn't sound like either of the two conditions you're facing warrant that. And if you really needed treatment, I think there's a way to manage it. Going back to the BPH, before I was diagnosed, I was getting up 2 or 3 times a night, got to about 4 times, and that's when I went in to see the urologist. Ultrasound show enlargement, MRI, biopsy, and the rest is history. First treatment was TULSA-PRO, and after doing TULSA-PRO, I slept through the night, and I was able to sign my name in the snow the few times it snowed in Atlanta. Then found that I had disease outside the gland, did SBRT, had no abnormalities on no abnormalities without problems urinating around the time of the treatment, but I'm pretty much back to the same as where things were before I started this, 2 to 3 times a night now, and a weaker stream and longer to pee. But I didn't have any problems during the course. And, sure, they're going to tell you a lot of stuff, but it just sounds like they're feeding you and you have 2 conditions that don't need treatment, so that you don't add 1 + 1 and get 2 and say, oh, now I need to treat it.
well, gosh, where I'm at is I really thought I was going to be able to do focal, but the problem there is that I likely have cancer on the right side of the prostate. The main lesion is on the left. I likely have cancer on the right that they can't see. In 2021, they found a spot on the right. 2 MRIs since 2021 didn't see it. I've had 2 biopsies total. The second biopsy also did not see anything on the right. So the urologist said something I did agree with. He goes, well, focal might not be so, whole gland would be better because focal might just kick it down the road. If you really do have cancer on the right, we can't see it. Focal isn't going to treat it. Okay, that makes sense to me. If that's,
Focal should always be looked at as kicking it down the road.
Yes.
Focal is not, 50 to 60% of people will come back. The early study, I misquoted that before, but Pavlovich quoted an early study that showed that at 1 year, the biopsies were 50% positive 1 year after TULSA-PRO whole gland. So it's getting better. And now they're showing up to the 80 or 90%. But again, biopsies aren't 100%. So just showing that in a biopsy doesn't necessarily mean you've cured the disease by doing it. But a whole gland treatment is going to improve it. But it doesn't sound like what you're telling me is bad enough that I'd want to wear a catheter for 12 days after focal treatment and come out of pocket and then come back a year later. And I've heard so many people who've done TULSA, be it whole gland or partial, who come back a year later and have to do focal treatment again. It's just, I think if you're going to have to do treatment, you ought to do it.
Yeah, at this point, I've ruled out focal. I've heard enough. I've heard enough corroboration that focal is a kick the can down the road sort of thing that it's like, well, okay, I think I can rule that out. I guess my biggest question now is, it sounds, from what I've gathered from the group is that MRI before biopsy is non-negotiable. That's always the case, regardless of whether it's your first biopsy or your 3rd or 4th or 6th or what have you. Is that a
absolutely? Absolutely. Pin the tail on the donkey is not a way to treat prostate cancer.
Am I correct that MRI basically shows them, okay, here's where the cancer is. Now we can go in and do the biopsy because we know where to poke the needles. Is that reasonable?
Essentially, yes.
Yeah.
Well, not so much we know where the cancer is, but we know where we suspect the cancer.
Yes, I'm sorry.
Yeah.
Because there can be other marks and there can be other the MRI can portray that there's something of interest, and it may not necessarily be cancer. I'm not saying that very well, Dr. Mark. Could you
No,
please
it's where to look for cancer. It's where to look for cancer, not
right.
Because the other thing that's interesting is that from Dr. Lawrence Klotz has shown that there are a lot of people who have their PSAs may go up, their MRIs, a well done MRI is clean and doesn't show any lesions, and you biopsy those areas, you can find cancer. But what's interesting is he's looking at the genetics of the tumor, and these are not tumors that spread. So the issue of focusing on, well, we're going to do random biopsies because you can get some cancer outside, doesn't seem to be the approach that we ought to be taking. If there's no lesions seen, then we probably shouldn't do the biopsy. If you have high biochemical markers, like a high ExoDx or one of those other tests, then you might push towards doing a biopsy. But if you don't see something, one of the big controversies now is, do you do the targeted lesion of what you see on the MRI alone? Or do you do that and then do 12 other spots around the prostate? I think probably the information now is that holding off on that, all things being equal, might be a better approach, and just looking after the lesions, biopsying those. Any other comments on that? Okay,
the only comment I would make is that some of the urologists will say, well, it's not blind because we're using an ultrasound and we can see things, which is in the old days. I mean, when I got my biopsy, it was an ultrasound transrectal biopsy. That's how they did it. But the definition that comes from an MRI is so much better in helping them target. And then there are still some of these guys who still do blind biopsies because they don't see anything. They don't see anything on that they can recognize on an ultrasound, so they just stick a needle in every quadrant, right?
Well, the problem is that we now have nano ultrasound or micro ultrasound, which I think is a 29 megahertz frequency on it. And the standard ultrasound machine we have in our office is probably about 3.5 to 5 megahertz. So the resolution difference between what they stuck up your rectum to get that biopsy might pretend to see your prostate there, or you know where the prostate is, but you're not going to have the resolution that the new nano ultrasounds or micro ultrasounds offer to allow you to visualize and say where to biopsy. So, I mean, the biggest problem with the nano ultrasound that I see is that it depends who's holding the probe. It's probably a lot more important to get an experienced person who knows how to look at ultrasound. I don't think that's a test where you can just take a bunch of pictures and show it and say, yep, that's it. Whereas with an MRI, you can hand it off to someone else who can read it and give you a good idea as to whether there's a Pyrides 2, 3, or 4, or 5 lesion on the MRI. So
Nano ultrasound is an MRI.
No, nano ultrasound is an ultrasound but it uses a very high frequency probe. So what happens, the higher the frequency on the ultrasound probe, the shorter the distance, the ultrasound, but you have much greater resolution. And I don't remember if it's the squares rule or it's just 3 versus 25 is close to 10 times more resolution. I don't know exactly how you would compare it, but the pictures are night and day different.
And a recent study that was just published and led by Clark's, and I forget the name of the study, I can look it up and tell you in a second, suggested that an MRI doesn't add anything to micro ultrasound.
Again, depending on who does it, the micro ultrasound.
Yes, depending on who does it, yes. But in this study, they found the results were actually better. And so the advantage was that men didn't have to worry about getting an MRI first.
Yeah, I posted that in the chat. The view
right, and what's the name of that study?
It was ViewMedi was the site. It was called Microultrasound versus MRI guided biopsy for prostate cancer diagnosis, the optimum trial results.
Optimum trial, there you go.
So again, the thing is, if you're sitting there and your doc says, I don't do MRIs before the biopsy, the next question to ask is, are you using microultrasound? And then the next one is, how many microultrasound directed biopsies have you done? I mean, and I'm looking at some other medical stuff, trying to interview and decide on a doc, and it's really hard to get the information to know if it's just a new toy in the office that they've got to use, or they've really done the research and they're part of the study. I would have no questions and qualms about going to someone like Dr. Klotz to do that ultrasound. But if my community urologist just tells me this, I'm not sure. So I don't know how we, sitting here not having that access, can get the information to know if, yeah, it's okay not to do the MRI. Any other thoughts, questions? Jill, if you want to unmic yourself or unmute yourself and present the story, we'd be glad to chat about it. We want to hear the whole information rather than just type back and forth in the chat window. But if not, and does anybody have any last minute comments here tonight? If not, have a wonderful, what's left, few hours left of the holiday, and appreciate everybody stopping in on their holiday evening.
I just wanted to say thank you for everybody. And it was very eye-opening and very, rude
How did you
awakening.
hear about us, Sully? Good.
I think it's on the Facebook, some Facebook.
Okay.
Yeah, cancer alternative treatments on Facebook.
Okay, sounds great.
Thank you. I'm a smarter man today. Thanks.
That's our goal. Night, everybody.
Can I just address Jill B for a second? I'm sorry we can't really help you. Here's the situation. We don't really do peer-to-peer because we're not equipped for it. Most of our moderators are volunteer, and so it's not up to us at AnCan to volunteer Dr. Mark's time. He can do that, but we don't do it for him. So we send people to Women and Angels if they want peer-to-peer advice, but we don't per se do it. We invite people into this forum, which is free and drop-in, to answer the questions as best as we can, and we have a lot of knowledge in the group, so we can be of help. It's very, very hard for moderators to address questions in a chat window when they're trying to moderate a group. It doesn't work. There are forums where you can post. I no longer participate in a forum for a whole number of reasons, although I was actually awarded something by Zero, Us Two, many years ago, but I don't go there. Dr. Mark does go to those forums. So if you post something in one of the forums and he sees it, maybe he'll respond to it. But I'm sorry that we can't help you more. At the same time, we absolutely respect that that you don't want to be identified, and that's just fine. But I'm sorry we can't help you.
Yeah, I wanted to mention with the forums now, my level of frustration is going sky high for discussing the point that febendazole and ivermectin are not a godsend that the medical community is keeping from people to cure their cancer. I got shot down and gone through royally, and one of the groups, Inspire, could be a good place for people to get information in that kind of setting, but it's been taken over by the conspiracy theorists who want to turn everything into a blue versus red battle.
Well, you see, and this raises, Mark, I'd love for you. This is good that this is also on the record because it's important stuff. We're working with a very well-respected urologist at an NCCN center on some survey stuff. And one of the things this urologist is interested in looking at is the strength of the written forums that are out there. And there are basically, there's 3 or 4. There's one by Mayo, there's Inspire, there's what we affectionately call Health Locked Out or Health Unlocked. We call it Health Locked Out because we're all banned from it. And then PCF just started its own set of forums, and you'll find all those forums on PCF. Now, if you would like to put down that observation, I'd like to forward it to the doc at the NCCN Center, because that's exactly the reason that many doctors are not comfortable. The reason it happens on Inspire is because Inspire is now run by Zero, and Zero does no moderation. And if I was Zero, I would be totally embarrassed to have my name associated with the information that's going on in there. But frankly, there's nobody at Zero who has enough knowledge to even moderate those groups. And so they've absolved the responsibility. And what happens is that when we criticize Zero, usually with good reason, we get into trouble. I had one of my sponsors come back to me the other day and say, why do you criticize Zero? Well, we criticize Zero because they're not doing a good job. They're quick enough to make videos about having a car run in their name at where was it today? The Charleston 600 or wherever it was.
And races.
Yeah.
This race, 50 mile a month or 60 mile.
Yeah, this they're very big on. Solid information to patients. They don't want to know. And if anybody holds them to task,
the other problem is the urologists have a loud voice, and these organizations have to protect the urologist. The urologists are the first point of entry for most of the people, and therefore they have more contacts with the drug industry and vendors of various sorts than radiation people do. So you don't really get a balanced, there's really not a balanced approach. And that's why you get MRIs may be done as opposed to should be done. As long as these groups continue with may, it really seems like the most important thing they're doing is supporting those at the lowest, providing the lowest level of care.
Yeah. But to go back to the fenbendazole ivermectin, it's a joke. It's a joke.
Well, it's not. It's not a joke. In a lab with an isolated single cell culture, they can have activity. The last time I looked, we're made up of a whole bunch of different kinds of cells, and fewer than 3% of the studies that show in vivo benefit work in vitro, and there are none in this area. Yet,
And were any of those prostate cancer cells, or were they other types of cancer?
No, they were. They were PC3 cells, PCA3. So it was a legitimate, and it's very impressive. But the fact of the matter is, it's like if you pull weeds out of your yard and you get all the dandelions, something else may now say, I've got a chance to grow, and starts growing. So it's a far cry to say that something that may have activity against one cell line is going to be effective in treating the disease. The other thing is it can induce a mutation in the clone of cells, so that you throw one thing at it, just, we throw antibiotics at everything, and what do? We end up having people who are now resistant, and resistant passed along through all the bacteria. I'm just not sure. If I saw some evidence, it would be great. But when you say there's no evidence, boy, look to get attacked.
Yeah, well, is there any evidence, not even in people, not in vivo, in people, in men?
In human cell lines, I haven't been able to find it. It may have been Harvard or Hopkins. There was one study done at one point that showed absolutely no benefit, but no studies that show that it's benefit in a live person to take it.
So I'm going to change the topic before we hang up. I just want to check in with you, Jeff, because we didn't ask you. How's this anxiety that you've been handling? Are you feeling any easier, or are you feeling worse and more confused?
I wouldn't say I don't know if I'm more confused, but I am not less confused. The BPH thing really threw me for a loop.
Yeah.
Because, this guy, I've heard from two people, yeah, you need to handle the BPH before you do the radiation. And the thing that dials up the anxiety there is, well, it takes, I've been told that it takes 6 weeks for aquablation to heal before you could get radiation. HoLEP would be the same. TERP would be 12 weeks before you can get radiation. And I thought, oh boy, that's, yeah. But then my half brother has had prostate cancer. Well, a doc told him, no, he had BPH. He knew that he had it, needed to get it. It was bad enough that he had to get it fixed. One doc told him, oh, you need to get it done before you get the radiation. So he went to another doc and he goes, no, you don't need to get it done. But, oh my God, well, that just.
So I think that's one of the points we made earlier, Jeff, is that it's, from what you've told us, there's no immediate need to treat either of these. So it sounds like your focus needs to be on finding the right person, and you're not finding that in Austin. You're not getting unbiased information from people who you should be relying on. Your brother-in-law or half-brother, the doc you've been talking to, these are not the people. It sounds like Dr. Moak might be a good avenue to figure this out, but you're not going to get rid of some of this anxiety. When I got my cancer diagnosis, it was like, oh my God, is my insurance paid? Do I at least have a week or two that I can get all this stuff? You don't get a diagnosis, you get a death sentence when you get that. And then you realize that's not true. The worst part for most of us is this trying to figure out how to do it, who to listen to, and you're going to get a lot of conflicting information. And that's why, I was in Atlanta and talked to great people at Northwestern, in New York City, at UCLA, and I traveled all the way across the country because I really did need treatment. My situation was not at all like yours. I needed treatment with advanced disease. Now I know that whatever comes up, whatever gets thrown at me, I've got people that I can go to that I can trust and rely on. That's more important in your case than finding who's going to do what or what they're saying at this point.
Yeah, trust is I mean, in capital letters. That's what I'm dealing with. Who to trust, finding someone to trust.
Okay. Well,
Trust one thing, like the urologist last week, he said things I agreed with, and I think he's, sincere, but there's, things are,
yeah, but Jeff, the first thing we said to you is get your ass out of Austin. You
Okay.
cannot rely on those docs in Austin. You got to get to an NCCN center or Houston Methodist in Houston or in Austin, in Dallas or in San Antonio. You got to get there. And as long as you keep going around and around in Austin, you're going to make yourself nuts.
Were you the person who said earlier that you had talked to Dr. Scholes?
No.
That was someone else.
I did talk to a guy there. I did talk to a guy at PCRI.
Okay. So, yeah, well, talking to the guy, one of the advisors there, we were all at the conference last year, and there was some information that came from some of their mentors that I think we would not necessarily agree with. It may be worth your while hopping on a plane, 2 hours, 2.5 hours. It's right near the airport, and you could go and talk to Scholes and figure out. And he's certainly someone who I think would garner trust or help you feel that. But, I think the information you're getting now is what's feeding anxiety because you're getting conflicting information and not good information.
Would you say MD Anderson is a NCCN?
It is.
Yeah, it is. Yep.
It is. And, see Moke. And if you need to see a urologist there, check in with Hugh Edstein and ask him who he sees. And go to his guy. He likes him. That's if that's where you want to get treated in Houston.
Hugh Edstein, did you say?
Hugh Edstein is the guy that leads the active surveillance. I know you've been in that group with him.
Okay.
So come into the active surveillance on Wednesday and ask him who's your doctor for me to make the appointment with there. But I think we've mentioned that to you in that group before, Jeff.
I'll look for that. I would have written it down.
Well, I know we mentioned it here last time. So I think that's really going to get you feeling a lot more comfortable. Because one can always and ask about the 5-alpha reductase finasteride, because that's something that can shrink the gland and hold PCA in check, and that might be something that you want to do.
Exactly, good suggestion.
Okay.
All right. Thank you.
Good night, everybody.
Good night.
Good night. Good night.